So the NEIA, the National Early Inflammatory Autoimmune Audit, changed its name last year from arthritis to autoimmune. It's actually been running for a good 6 years. We're now in the extension period, which runs until October 2027, and it refreshes. Now, it's actually a HQIP commissioned and mandated audit. HQIP, Health Quality Improvement Partnership, are tasked by the NHS in improving quality and raising standards. And they go about that by putting in place audits, because what we know about audits is once you start measuring something, you automatically start improving it. And then you can show improvement, and you can also highlight areas that need to be improved and targeted. So we collect data on all newly diagnosed cases of early inflammatory arthritis across England and Wales. Since September 2023, we've added in a broader range of diagnoses, including the connective tissue diseases and the vascular diseases. But the original audit was set to improve standards in early inflammatory arthritis. By collecting data and measuring standards against what we call the NICE quality standards. And the NICE quality standards say a couple of very important things. First of all, patients should be referred promptly. It's a target of 3 days for GPs to refer. Secondly, we should see them promptly. It's a target of 3 weeks. And thirdly, that we should start immunosuppressive or DMARD therapy within 6 weeks of that referral. And in fact, the most important of all those is the 6-week treatment target. And we know that because we've been back and looked at the data over the 6 years. And what we've shown is that the outcomes are best in the group that start DMARDs early. It doesn't just improve physical outcomes, it improves mental health outcomes, and it improves work outcomes. So we now focus on that 6-week target, and trusts are measured against that, and then measured on the percentage of patients that start a DMARD within that 6-week target. And what we know is that over time, standards have gone up. And last year, which has been published data, 60% of patients across England and Wales with early inflammatory arthritis started a DMARD within 6 weeks. The South West is a very good region in terms of starting DMARDs in 6 weeks and has good outcomes. But some of the other regions struggle with that. London's a particular problem. Outcomes in London are not as good because they struggle to get the DMARD started within 6 weeks. And there's a little bit of a north-south divide as well. The northern regions in England struggle and Wales struggles. So one of our missions is to try and improve standards across the patch and pull everyone up to that good standard. What we've found quite clearly is that there's big variation in how well we're doing across England and Wales, and there are probably a number of reasons for that. One reason is resource, and we know that some trusts are better resourced than others. But it's also about planning your resource and planning your pathways. And what we have shown is the trusts that have got good early inflammatory arthritis pathways do better because their patients are channeled through the right channels and get seen and then treated early. Another concern of ours is that some trusts are showing that they are seeing patients promptly, but they're delaying treatment. And that may be because they're waiting for patients to go through tests or waiting for them to see nurse specialists and so forth, and having a bit of a bottleneck at those points can be a problem. So there's pros and cons to that. Firstly, I feel it gives us ownership of that audit, ownership of the data. But secondly, it creates a barrier to putting it in because it's not being done automatically. So there are pros and cons. We're working very hard at trying to improve awareness. And we know that awareness is pretty good, but also improve uptake and engagement. Those are the things that we're really working on at the moment. About a year ago, we introduced a really exciting little extra, which is the dashboards. And the dashboards give you a very visual picture of your performance, overall performance, and everyone else's performance. It's absolutely fascinating. So, and it's publicly accessible. You don't need to log in. If you do log in, which of course I would recommend you do, you can adjust dates. So you can get more data if you log in. But just going onto the audit platform and looking at the dashboards, and we give you some very important highlights. First thing we do, it shows you a pie chart, what proportion of your patients are referred within 3 days by their GP. The second one shows you what proportion of your patients you're seeing in 3 weeks. The third one shows you what proportion of patients you're starting treatment within 6 weeks. And then the fourth pie chart circle gives you your remission rates at 3 months. And I think what you'll find, if you look at them, if you look at the overall data, then you can pick out your own trust or other trusts. neighbouring trusts, competitors. And I think what I hope you'll pick out, and which seems quite clear to me, is that the trusts that are getting their patients started on a DMARD within 6 weeks are also the trusts with good remission outcomes. And that's quite important. If you scroll down the page, you can see even more information. You can see some stats on average time to being seen, but there's a little set of data at the bottom which shows you the proportion of patients that are being put in and their split of their diagnosis. And again, you can look at it overall and you can break it down by trust. And so you can see what the patterns are of patient entry into the audit. One of the pleas to the departments over the next couple of years is to try and even up the data you're putting in and try and put in a good spread of data. It's not very onerous. We're only looking for incident data. So you only put the CTDs and vasculitis patients in once at the beginning. And it's really good to have an England and Wales wide picture. How common are these conditions? Are they presenting in different regions? Are there factors that we need to take into account? And what we're hoping to moving forward is that NICE has just published quality standards for the rarer conditions. And amongst those quality standards, it's asking us to make sure that we see these patients promptly and we start treatment promptly. And of course, you'll be able to evidence that and measure it with the audit data. There's a really good example in last year's national report, which was the Leicester experience. Leicester is a really large hospital, catchment population of 1 million, large numbers of patients going through. They were not doing well on the audit. They had poor stats. They looked at their performance. They picked it apart. They process mapped it. And actually, without any additional resource, but with clever use of what they had, they've turned it around. They are now the top recruiter. They've got amazing stats. They clearly demonstrate, it's always worth looking at Leicester. I always show people Leicester. They clearly demonstrate the link between early treatment and good outcomes. So they have the best stats for the 6-week treatment and they have the best remission rates. And you can see that really clearly. So that's a really nice example. But on a much smaller scale, in our trust, our registrars have used the data to pull it apart and look at things. So we did something really interesting. We looked at the data for GCA and we only put small numbers in, 7, 8, 9, that sort of numbers. We're a smallish trust, catchment population 350,000. And then we looked at all our surrounding trusts and they're all putting in many more than us. And we've got a bit we're missing these. So we've done a little project comparing data across the trusts. And one of our registrars who's going to present actually at BSR is looked at all the factors influencing those diagnoses. Did we have the pathways right? What were we using for diagnostic tests? Were there problems with our service? And we did have a problem with our service in that we don't have routine access to vascular ultrasound, which is regarded as best practice these days. And we were having to use temporal biopsies, which are a slower process and less ideal for the patient. We have, based on that data, written a business case, which we're hoping will take things forward. At the moment, we're waiting the outcome of that, but we are hoping that we've been able to utilise the data to identify problems with our practice and hopefully improve the service for the next generation of patients.